Hi everyone, my name is Julia LaValle and I will be doing my Grand Rounds presentation this week. So my patient is DG. She's a 37-year-old female. She has a past medical history of chronic fatigue, mild depression, and seasonal allergies. She's currently taking methylphenidate, XR, fluoxetine, birth control pill, and cetirizine as needed. She has no surgical history. Her family medical history: her mother has hypertension, her father also has hypertension and Crohn's disease. Her social history: she's married with 2 children, ages 6 and 4, and manages a neuropsych department at a local hospital. She exercises regularly about 4 to 5 days a week, consumes a healthy diet. She consumes about 2 to 3 alcoholic beverages per week, and has no illicit drug or tobacco use. So the patient's chief complaint is hypersomnia and chronic fatigue. She has been experiencing hypersomnia for over 15 years. She reports waking up each day in a fog and experiences excessive daytime sleepiness. The patient states that she could sleep for 15 or more hours each night, but forces herself to get up with an alarm clock. She states she never grew out of the sleepy teenager phase. She reports drinking 4 or more cups of coffee each day. She states that she has to keep her body and mind moving throughout the entire day in order to stay awake. She admits that if she sits down on the couch to read or watch TV, she will fall asleep within minutes. The patient had a sleep study done years ago, which suggested possible narcolepsy. She was put on Concerta for stimulation and fluoxetine for potential depression-associated fatigue. These medications have helped her a little bit, but her symptoms persist. So the review of symptoms: for constitutional, she does report excessive fatigue, but denies fever, chills, loss of appetite, weight loss, or weight gain. For HENT, she denies vision changes, yellowing of the sclera, nasal discharge or congestion, sore throat, and dysphagia. She denies shortness of breath, cough, wheezing. For respiratory. For cardiovascular, she denies chest pain or palpitations. For GI, she denies abdominal pain, nausea, vomiting, constipation, diarrhea, or blood in her stool. For GU, she denies dysuria, hematuria, or urinary frequency. For MSK, she denies joint pain or stiffness. Endocrine denies polyuria, polydipsia, goiter, heat or cold intolerance. And mental health and neuro, she denies depression, anxiety, memory loss, or disorientation. For her physical exam, her vital signs: her temp was 98.1 Fahrenheit, her heart rate was 88, her blood pressure was 110/72, respiratory rate 16, and O2 sat 98%. Her general appearance: she was a well-appearing, alert and oriented ×3, and it was in no acute distress. For HENT, she was normocephalic, perla, no scleral icterus, ear canals were patent, the TMs were visualized and normal, her nares were patent, oral mucosa moist, no tonsillar hypertrophy or exudate, her neck was supple, had a normal thyroid. Respiratory: had non-labor breathing, normal chest expansion, lung sounds were clear bilaterally. Cardiovascular: she had no thrills, no murmur or gallop, regular heart rate and rhythm. GI: her bowel sounds were normal. She had a soft, non-tender abdomen with no organomegaly or masses. For MSK, she had normal muscle strength and tone, no joint tenderness. For mental health and neuro, she had normal mood and affect, normal gait, her reflexes were +2. Her breast exam: she had no nipple abnormalities, no dominant masses or tenderness to palpation, and no axillary or supraclavicular adenopathy. So the differential diagnoses: the first is idiopathic hypersomnia. This is described as hypersomnolence with unknown etiology. It's characterized by excessive daytime sleepiness despite adequate sleep quality and often excessive sleep quantity. Obstructive sleep apnea is a sleep-related breathing disorder characterized by recurrent episodes of apnea due to partial or complete blockage of the upper airway. Narcolepsy is a disorder of hypersomnolence that causes excessive daytime sleepiness and may or may not include cataplexy, which is sudden muscle weakness triggered by strong emotions, which is seen in narcolepsy type 1, and then narcolepsy type 2 does not include cataplexy. You also see disrupted nighttime sleep, sleep paralysis, hypnagogic and hypnopompic hallucinations. And hypnagogic hallucinations happen as you're falling asleep, and hypnopompic hallucinations happen as you're waking up from sleep. And then depression, which is a mental health condition characterized by persistent low mood, loss of pleasure in activities, lack of motivation, weight changes, sleep disturbance, fatigue, and hopelessness. So for the plan of care, the diagnosis is idiopathic hypersomnia based on the patient's symptoms. However, further diagnostic testing needs to be done to confirm this diagnosis. The pharmacological interventions, no new pharmacological interventions are needed at this time. However, the first-line treatment for idiopathic hypersomnia is modafinil, which is a central nervous system stimulant. Other treatments that can be used are methylphenidate, which the patient is already taking, amphetamines, and non-sodium oxybate. For many non-pharm interventions, such as prolonging sleep and napping throughout the day, are not effective for idiopathic hypersomnia. However, some patients have found that keeping a sleep journal and trying CBT is effective. For diagnostics, so the Epworth Sleepiness Scale is something that we use often in primary care. It assesses subjective sleepiness, which can be repeated in future visits to determine the efficacy of treatment. Patients with idiopathic hypersomnia often have scores greater than 10. Polysomnography is what we know as a sleep study. It records the sleep stages, respiratory effort, O2 sat, heart rate, and it can be used for this patient to rule out central sleep apnea and obstructive sleep apnea. The multiple sleep latency test is the day after a sleep study, and it's a series of 5 daytime nap opportunities for the patient to objectify the extent of their daytime sleepiness. Patients must have a minimum of 6 or more hours of sleep during the sleep study the night before for the MSLT to be accurate. The ICSD-3-TR diagnostic criteria for idiopathic hypersomnia is daily periods of irrepressible need for sleep for 3 or more months. The cataplexy is not present, and the sleep study and the MSLT findings rule out narcolepsy. So for patient education, you would talk about medication options and side effect profiles, keeping a sleep journal to track sleep habits, using watches or other devices to track sleep and wake times. Some people may benefit from CBT for support in developing healthy sleep habits. For referrals, this patient was referred to neurology sleep specialist, and there they can do the sleep study and the MSLT. And then therapy for CBT if the patient would like to try that. And for follow-up, the follow-up is usually for symptom severity and side effects of medications, and that can be done every 3 to 6 months while the patient is being evaluated for this condition.